Thank you for joining us today. I want to welcome everyone to this installment of the STS 2022 Webinar Series. This series features presentations and panel discussions on a variety of topics relevant and important to cardiothoracic surgeons. The topic today is arrest after cardiac surgery. Is your team ready? Please note this webinar is being recorded and will be available tomorrow morning on the STS website and YouTube channel. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. At this time, I'm pleased to welcome our moderators, Dr. Awori Hayanga and Dr. Anna Ciullo. Dr. Hayanga, welcome. I will now turn it over to you.
Few crises test critical care capabilities more than the heart stopping suddenly and unexpectedly after a cardiac surgery procedure. Good evening. On behalf of the STS, welcome to the webinar. Tonight, we present and highlight the team-based emergency response to the management of cardiac surgery patients who suffer sudden postoperative cardiac arrest. Our panel of experts will discuss the implementation and framework of cardiac surgery advanced life support protocols and their utility in failure to rescue algorithms. I am joined tonight by my digital moderator, Dr. Anna Ciullo, who will also be monitoring the chat. Dr. Ciullo is an assistant clinical professor within the Division of Cardiothoracic Surgery and Department of Emergency Medicine at the University of Utah. Her primary clinical focus is mechanical circulatory support and the post-operative care of the cardiothoracic surgery patient. Dr. Ciullo will introduce the panel. Dr. Ciullo.
Good evening, everyone. Our illustrious panel tonight brings a great depth of expertise and experience in perioperative care. Our panel speakers are Dr. Adrian Levine, Dr. Subhasis Chatterjee, Dr. Nick Teman, Allison Kirkner, and Aaron Morton. We are also looking forward to the panel debate at the end of the three presentations, and we encourage you to send us your questions via the chat link as we will be monitoring this in real time. To start us off from the United Kingdom, where it's almost midnight, Dr. Adrian Levine is currently a retired cardiac surgeon. He has taught CALS around the world for nearly 18 years, and we'll talk today about how far we have come with CALS. Dr. Levine.
Good afternoon, everybody. Adrian Levine here from the UK. I'd like to present the CALS course, how, why, and how far we've come in the last 18 years. In 2003, my colleague, who was then a resident, noted a large difference between ALS arrests on a general medical ward and cardiac arrests post-surgery on the cardiac intensive care unit, which he just started work on. We brought together a team of dedicated clinicians to see whether, firstly, there was a problem, and secondly, what could we actually do about it? Well, is there a problem? I think this is the best paper on it. This is a paper from the Annals in 2014, which demonstrates, looked at nearly 80,000 patients in 17 hospitals in Virginia between the years of 2001 and 2011. It demonstrated across these 17 centers that the arrest rate varied between 3.5% and 8.5%. But even more worrying still was the fact that the mortality varied between about 50 and 70%. So cardiac arrest post-cardiac surgery obviously was a problem. So what did we do about it? Well, we can sum up the whole of CALS in one slide. If your patient arrests post-cardiac surgery in the early phase on the ITU, if they have VF, you can give them 3 stacked shocks. If they're asystolic, you epicardially pace them. If they got PEA and they're paced, turn the pacing off to see if there's any underlying VF. If these 3 simple things do not work, then start basic life support with CPR and prepare for emergency restenotomy within 5 minutes. To make this happen, you need a team. And this team, as you can see, has about 6 to 7 people in it. The 2 important people are non-task focused. They're the team leader and the ICU coordinator, and they get things working. Person 1 is the nurse looking after the patient who will be giving the CPR Person 2 is the airway person. Person 3 is the electricity person. And as you can see down at the bottom are 2 people about to do the operation. To make the operation as easy as possible, we've produced this, the 5-piece set, which is literally a knife, a wire cutter, a wire puller, a spreader, and suction tubing. And that is all. That's the whole of CALS in 1 minute. So how do you tell people about this? Well, the way we tell about it is obviously academics. And the first publication we did was a publication in the Annals in 2006, demonstrating that if you taught people, they opened the chest more quickly and did fewer dangerous things whilst they were doing it. Then we turned our gaze to guidelines. Our first guideline came out in 2009 with the Europeans. Our third one was a consensus statement with the STS in 2017. Our fourth one was with the ERC and the AHA in 2021. And for complete global domination, we've got the Australians coming on board this year. So how do you teach a thing? So the first course we did was in November 2004. We had 12 candidates and 13 lectures. Here's a note to anyone ever wanting to do stuff like this. Always have more candidates than you have lectures. We evolved with this over time. Now we have a schedule, a provider course, which is very, very much based upon practical and moulage skills. Because we have so much practical and moulage stuff, we need a manual, and this is the 4th edition, the American manual. And we also have a large amount of e-learning. But because the practical skills, we have to have a mannequin, and this is a specially designed mannequin, which allows restenotomy, internal cardiac massage, and internal defibrillation. We also have to have relatively high fidelity, but low cost simulation software. And this is some that we've co-developed with a Danish group. Obviously, we need to keep a database of all the people we've trained because we need to retrain them every couple of years. And the way we do this is via certification. And because we train so many people, we need to train trainers. And therefore, we've been running train the trainer courses for the last 8 years or so. So it's been taught all around the world. We started in the UK in 2004. We moved to Europe in 2008. We arrived in the US in 2011, and as the Beatles demonstrated, you know one unless you crack the US. In 2012, we went to Southeast Asia, then South Africa, India, China, and Israel. And finally, in 2017, we went to Australia and New Zealand. I went there and I liked it so much, I'm emigrating there with my wife. So now, as you can see, it's taught at over 120 places throughout the world regularly, from Anchorage, Alaska, all the way to Dunedin on the South Island of New Zealand. To give you an idea of some statistics, in 2004, we did 1 course. This year, we'll do 500 courses around the world. Next year, we're looking at around about 700. As I've said, we've taught it in around about 120 centres, and these are growing at 2 to 3 a month. I've just signed up another centre in South Africa today. We've taught just over 14,700 people over the last 6 years. So, in conclusion, if you're going to develop something like this, you need a simple idea. And I think the simple idea came from my colleague Joel, who noted the difference and wanted to do something about it. It's obvious when you're doing something like this that the foundation for any course like this, which is going to become international, is academics and very strong academic foundation. The only way you can do this, the only way that you can get the academic foundation right, is surrounding yourself with the right people. And finally, again, if you're going to do something like this, you have to be ready to evolve. At no point when we started this did I ever imagine that we would spend a long period of time developing e-learning software. Thank you very much, everybody.
Thank you very much, Dr. Levine, for that excellent talk. Moving swiftly to our next speaker, who needs very little introduction. Dr. Chatterjee is an associate professor of surgery in the divisions of trauma, acute care surgery, and cardiothoracic surgery at Baylor College of Medicine. He is the director of the Thoracic Surgical ICU and ECMO program at Texas Heart and an active member of the STS Workforce on Critical Care. His talk tonight is entitled, Arrest After Cardiac Surgery. Is your team ready? Dr. Chatterjee.
Great. Thanks very much. So we will focus on data, results, and outcomes, and how to actually do it with failure to rescue. So we'll look at cardiac arrest after cardiac surgery, a survey of current practice, what to do, how to do it on top of Adrian's observations, failure to rescue, and even beyond counts. So when you look at the results of chest reopening, there's not a lot of data in the literature, but this study out of Papworth almost 20 years ago shows that in situations of about over 800 cardiac arrests, about 10% of cases required chest reopening, and only about 25% of patients overall survived. But what they did find was that overall survival was better if they were reopened within 10 minutes and if the arrest occurred less than 24 hours after surgery. But in addition, what's interesting is that among survivors were more likely to have bleeding and tamponade as a finding and cause of a result of arrest, and those that did not survive were more likely associated with poor cardiac function. The same group described their scoop and run strategy of chest reopening, where basically they took patients on the ward, brought them to the operating room or to the ICU, and reopened them. And they had similar observations. Again, what you'll note is that among survivors, most commonly, bleeding and tamponade was the predominant pathology. So that's important to keep in mind. This observational study of a survey of over 350 different clinicians throughout the world looked at programs in terms of resuscitation after cardiac surgery. So these were intermediate volume programs that averaged between 500 to 600 cases a year. There was just about a 2% cardiac arrest rate. You'll see about a quarter of the patients required resternotomy. And it's interesting, amongst these clinicians, only less than 10% noted that they routinely practice cardiac arrest situations, even though 80% of surveyed clinicians thought that practicing would be worthwhile and a good idea. And what you'll see here is that in general, what the decision about reopening the chest should be made within 5 to 10 minutes, and getting the chest open, after VF arrest within 5 minutes is associated with optimal outcomes. Now, the surgeons were also surveyed to see if appropriately trained personnel, even if they were not surgeons, would they be comfortable with the chest, with having them reopen the chest? And you'll see about 60% thought that this would still be appropriate. Now, what is necessary in order to create a CAL situation and to have a successful cardiac arrest resuscitation team? Well, just like anything else, a high-performing CV-ICU team is necessary. Indeed, to be able to take care of the elective situation and the routine perioperative care with a high-performing team is absolutely critical before focusing on an acute emergency like cardiac arrest. This starts with an adequate handoff that occurs between the operating room and the ICU to ensure that adequate information, especially with respect to bleeding and ischemia and other concerns, are known so that the ICU team can be looking out for things ahead of time. It's critical within the framework of teamwork that issues that are barriers to effective teamwork and creating appropriate improvement activities are already done. And these are necessary ingredients for a successful ICU team throughout the year. And it's especially important in an acute situation like a cardiac arrest. And this is really relevant, really in terms of the different staffing models that exist. A few years ago, we looked at the staffing models that exist within cardiothoracic ICUs. And you can see even after hours, 8 to 10 different providers can be available whether it ranges from intensivists, cardiac surgery fellows, PAs that are available at night. And this is especially relevant at night in open ICU. So how an ICU is staffed at night can be highly variable and can influence how a cardiac arrest is responded to. Now, you've seen this before. This is the resuscitation statement. And this you've seen just now. I'm going to make a few highlights and comments with respect to cardiac arrest and approaching the algorithm. It is different than a standard when the MICU team arrives for a standard code within that. So a couple of observations about the critical roles of the team. So person one here, this is a person doing external chest compressions. In this setting, you have an arterial line most of the time, so you can monitor as long as you can get a systolic of 50. That's usually going to be successful in terms of preserving brain activity. It's important to recognize to rotate people around to be able to make sure that good chest compression occurs. The airway team, it should be experienced if they're not intubated. If they're intubated and you have an IV access situation, remember, you can give your drugs through the endotracheal tube. Defibrillation, as Adrian mentioned, you don't wait 2 minutes between shocks. You stack your shocks one on top of another, usually about 5 seconds apart to see if it works in appropriately shockable rhythms. As the team leader, this is the slot number 4 here. This is often the intensivist. This person needs to be thinking ahead, whether in terms of initiating resternotomy, calling the ECMO team, and getting an echo, getting a point of care ultrasound immediately. I think this is what's really changed within resuscitation over the last 15 years or so, is to be able to help point out by point of care echo, perhaps this is clearly a tamponade situation or that we can attribute to. It's important to be cautious with epinephrine. You don't want to blindly give 1 milligram of epi routinely as seen in other code situations. And of course, communication is necessary. This you see here, it's important to simplify your tray that you have at your own institution. So can this be taught? I think Adrian is one of the world leaders in being able to do this. I thought this was an illustrative study looking at 24 people who took the course. And basically, you can see a variety of different situations that they were taught to go through to be able to practice for resuscitation. And you can see here the clear improvement that the clinicians provided with respect to rapidly getting better. And I think one of the things that's important about the team dynamic and why it's important to practice this is a concept of transactive memory, which is that within a team dynamic, sometimes when you just do it once every 6 months individually, you forget, what to do. You're really focused on what you individually are doing. But when you routinely practice it, your transactive memory occurs. Not only do you know what to do, you know what the other people are supposed to do, and you feed off each other, and thus you form a real team. So it's really important to facilitate that. Now, where does cardiac arrest fit within the entire concept of failure to rescue? Now, why this is important is when you look at POCMA, or phase of care mortality analysis, it's important to understand that about 25% of deaths after cardiac surgery occur in the intensive care unit. So opportunities for improvement in the ICU are really important for a program. Now, failure to rescue takes a look at 4 major complications: prolonged ventilation, stroke, renal failure, and reoperation. And it looks at, are we able to rescue these people so they don't die with one of these complications? And here what's really interesting is really a lot of the variation between different hospitals really comes down to failure to rescue. For example, here, the difference between high and low performing hospitals is not the number of overall complications or the frequency of major complications. But the reason there's a significant difference in mortality is really highlighted by the difference in failure to rescue, especially after major complications. And this right here shows the variation amongst hospitals. The major complication rate, you can see the median is around 10, 11%. You see the mortality rate difference. The median is about 2%. The interquartile range is very narrow. It's 1.5 to 2.5%. And finally, you can see the FT, the failure to rescue rate, is about 12%, with a range that's in that 10 to 15% range. So clearly, failure to rescue is really the major difference. Now, let's talk about some special situations where does ECMO fit into this? So ECMO after cardiac arrest, there are two major publications that are out there, each with about 23 to 25 patients out there, and you'll see about a 30 to 35% successful in-hospital survival rate. How do you weigh resternotomy versus ECMO? I think this is highly individualized. This depends on the program, the patient, but in general, resternotomy is more successful in the first 24 hours, and if the etiology is going to be bleeding or tamponade. On the other hand, ECMO is probably the better way after 24 hours or more likely ischemia. Again, sometimes they work together. And finally, targeted temperature management after cardiac arrest. The summary of the literature nowadays is that there's no need to target a lower temp of 33. Typically, just aiming for normothermia is satisfactory. So with that, thank you.
Thank you so much, Dr. Chatterjee, for that great presentation. Next up, we have Dr. Nick Teman, an assistant professor from the University of Virginia, where he is the medical director of the adult ECMO program, as well as the co-medical director of the thoracic and cardiovascular surgical ICU. Dr. Teman is going to share his insights on how to build a CALS program. Dr. Teman.
Thank you very much to the STS for the opportunity to talk about our experience at the University of Virginia in building a CSU ALS program. I have no disclosures. I want to talk about a few key components that I think are necessary when you think about how to build your CSU ALS program. And I want to encourage you to think about these kind of in this order. I think the first thing is that you have to figure out who are the key players at your institution that you have to get buy-in from. You have to create your team. You have to develop a training plan. And then you have to figure out how your resources and what your limitations may be, and how that plays into the overall plan that you have in place. And I'll talk about each of these individually. The first and most important, I think, is to get buy-in from the key players. You have to figure out who are the stakeholders at your hospital, who are the people that are going to be scrutinizing your program, who are the people that are going to be looking at any adverse outcomes or complications, and make sure they're on board from the get-go. And this is going to be different for every center, but I'll talk about a little bit what we encountered in our experience at UVA. The first was myself and my colleagues, the surgeons. Getting buy-in from the surgeons to have people that are not trained in surgical training programs, reopening chests, getting buy-in so that our patients won't be following traditional ACLS protocols and won't be having the normal pathways for a cardiac arrest. Really important to get the surgical team on board. The ICU staff, we're asking our nurses to do something that they haven't been trained in. We're asking in our case, our APPs to open a chest, which can be pretty intimidating to some folks, and asking the ICU leadership to kind of embrace this different philosophy. So it's really important to make sure that the ICU staff and everyone that's going to be involved in actually carrying out the protocols are engaged and invested from the very beginning. In our case, we had to talk to the lawyers. So there were a lot of medical, legal, and ethical concerns from different members of our teams, and getting buy-in from our legal team, making sure that we were covered from a medical legal standpoint was very important. And then finally, as you all can imagine, the hospital leadership and various committees have a vested interest in keeping, making sure that things are moving the way they should be, and again, watching for any adverse outcomes. So hospital administration, the chief medical officer of the hospital, different committees, in our case, the critical care committee, resuscitation committee, all had to kind of buy in. So a lot of meetings, a lot of pre-work before we even started the program to make sure that everyone was on the same page about this. And then it's really important to create your team. And I really encourage you to think about who you have at your institution that can be kind of leaders of this. And I really encourage you to have a multidisciplinary team. As an example, this is the group that we brought with us on our first training program when we initially did the CSU ALS training program. So we had ICU nurses, nurse practitioners, surgical residents, intensivists, ECMO specialists, and really created this very diverse, multidisciplinary team, because that's what you need. You need success. You cannot do this by yourself. You cannot do this in a vacuum. You really need a lot of really talented people that you surround yourself with to be successful. Next, you need to develop a training plan. How is this going to work? What is it going to look like at your institution? And it's going to vary from institution to institution. In our case, you have to figure out who is going to be trained. And you have to think about, is this going to be just permanent nurses, or are we going to train off-service nurses? Are we going to train our entire intensivist staff? Or are we going to train all of our surgeons? And is this going to be just in the ICU? Is this going to be in the step-down unit? How are you going to handle the issue of traveling nurses? And these are complex issues that have only become more complex with the COVID pandemic and other changes in staffing. So what we determined was that we were going to train our ICU staff, and our ICU staff was going to be mobile. So we still offer this protocol on the step-down unit, but the ICU team moves to the step-down unit and takes over the management. So the step-down nursing staff and others are aware of it, but they don't have to go through the extensive training. We haven't trained any of our traveling or off-service nurses, but we have a core group of nurses in our unit that provide the support when we need to implement this. How often is the training going to occur? Remember that this is a high stakes, low frequency event. So you have to keep your skills up. You can't rely on in the moment and real time CSU ALS activations because it may not happen that often. So how are you going to do the training and how are you going to keep those skills fresh? And along those lines, what are you going to do to kind of reinforce these skills? So in our case, we do mock codes. This is an example of that from one of our training sessions. And then we also bring our APPs, who are the ones that are opening the chest in this scenario. We bring them into the operating room, and they spend time with our surgical fellows and our surgical faculty, watching sternotomies, watching chest closures, participating and helping with those things, so that the first time that they're seeing sternal wires or a sternotomy is not when they're trying to reopen the chest in an emergent situation in the ICU. They get more comfort with just the idea of prepping and draping. They get more comfort with the idea of opening a chest and how to take out sternal wires and things like that. I think it's important to recognize the resources that you have. So who is going to be opening the chest? Do you have 24-hour resident coverage? Do you have APP coverage? Do you have intensivist coverage? Or will be bedside nurses that are doing this? So recognizing who do I have at my institution that can provide these services and focus on that. You know, I'm very privileged to work at an academic institution where we have a 24/7 coverage with residents and APPs, and we have people that have experience doing these things and surgical fellows that are readily available, but not everyone's going to have that. So look at your own program, look at your own institution, and figure out what resources do I have that I can use to provide this service to my patients. And again, where is this going to take place? Is it going to take place in the ICU? Is it going to take place in the step-down unit? Are we going to do this in the operating room? You have to kind of figure out what resources you have available. It's also important to figure out a system in place. So if a patient is having a cardiac arrest, the system that we have in place for notifying people, one is the bedside nurse will kind of yell into the hallway and activate the system. Everyone in the ICU will kind of converge there, but there's a lot of folks that aren't in the ICU at this period of time. So what we have is what we call an open chest blast page, but it's basically a page that goes out to a paging group that just says there's an open chest, this patient in this room. And that goes out to the surgical staff, the surgical residents, the operating room staff, the anesthesiologist, the blood bank, everybody that needs to know and respond that may not be present in the ICU at that period of time. So I encourage some sort of kind of broad-based notification system to make sure that everybody's aware of what's going on. And I want to give you some tips and tricks, some pearls that I've come across that we developed here at UVA. Again, nothing terribly novel, but things that we found that work really well for us. So one thing is, I think it's very important to eliminate any confusion about which patients are candidates or not. So what we've done is we have signs outside of every patient's room that says, that this is a CSU ALS patient. It has the date, which is 10 days from the day of their sternotomy. It has their name, and that travels with them. So this picture is actually from our step-down unit. So the signs travel with them when they leave the ICU so that there's no confusion. Everyone knows when this patient is a CSU ALS candidate and when they're not. And I think it's really very important to make this standardized and consistent. If you have a system where some attending surgeons want their patients to be on the protocol and some don't, or some patients will be and some patients won't, it gets very confusing, and there's a lot of chaos in a moment where you really want things to be streamlined and organized. So what we've said is that every adult cardiac surgery patient who's within 10 days of their operation, who has a full sternotomy, is a CSU ALS candidate. No exceptions, LVADs, transplants, anything else. Because again, in the heat of the moment, when that time matters to get back into the chest, you don't want to be trying to track down the fellow, or track down the attending and decide whether this patient is a candidate or not. So we just say it's everyone, and that makes this very straightforward and very easy. I think it's important to make sure that your equipment is readily accessible and to avoid redundancy. When we first started this system, we had about 5 different sets of open chest trays and different things like that. And we really streamlined this process. And so this is what we have done. And I think this works really well for us. But this cart on the left is a Pedigo cart that opens up to basically be like a Mayo stand for operating. And on top of the cart at all times is a pack with drapes and gowns and things like that, a pack of internal defibrillator paddles, and are given quick to the chest tray, like Dr. Levine talked about. It's just got those instruments that we need. That's all that we need to get in the chest. Now in the cart, we have other instruments like a full open chest tray to be able to go on bypass or repair a vessel or things like that, along with other instruments. And that's what this other cart here is all the supplies that we need to basically have a mobile operating room. But really the key at the very beginning is, how do I get in quick, and what do I need to get in? Finally, I think it's important to publicize your successes and learn from your failures. So this is an example of an email that was sent out from one of our intensivists. And this was after one of our very first CALS or CSU ALS responses. And I want to highlight the second paragraph where just a year ago, if this had happened, this patient would still have his chest open, would be on CRT, would be in rough shape clinically, and instead today we're going to extubate him. So it's these this kind of positive feedback that goes out to the team, which really motivates people and kind of reminds everybody why we're doing this and what we're trying to accomplish for our patients. Also, important to learn from your failures. You know, in every case, whether it's a success or a failure, we have a debrief session where we talk about what went well, what didn't go well, what we can improve for the future, what systems issues need to be addressed, and how we can make things better for the future. And it's this constant positive and negative feedback that really makes things work more efficiently and work better for our system. And we learn from each and every case. I think, you know, there's the other final point I want to make is to not overthink this. There's no reason to reinvent the wheel. There's no reason to make this more complicated. Dr. Levine and his colleagues have put together a very smooth and efficient system that works very, very well. And so use the algorithms that we have here, use the roles that we have here, and if you need to modify that for your system, that's fine. But again, I wouldn't overcomplicate it. I wouldn't overthink it. I would use the kind of tried and true efforts that people have already used. I mentioned the importance of having a strong team and a great team. Unfortunately for all of you, I have the best team, but I want to acknowledge all the folks that are on this screen, as well as the remainder of the folks that work here in the TCV ICU at UVA. We've got a great team in place that's been doing excellent training for several years and an efficient system. We've had 2 CSU ALS activations in the last 48 hours that went very smoothly thanks to the efforts of these folks and others. So I look forward to the panel discussion and thank you for your attention.
Thank you very much, Dr. Teman, for that insightful talk, and really to the panel for these excellent talks that we have been listening to. I would like to invite the entire panel back to the stage, and we will also be joined by Aaron Morton, who is the president of the Association of Physician Assistants in Cardiothoracic and Vascular Surgery. Dr. Morton received his doctorate from the University of Lynchburg and is the lead affiliate provider at the Emory University Hospital CVICU. He is currently the president of the Association of Physician Assistants in Cardiothoracic and Vascular Surgery and serves as the editor-in-chief of the JAPA-CVS.
We are also joined by Allison Kirkner, a nurse practitioner at UVA and manager of the cardiovascular APP program. Welcome, Aaron and Allison. So our first question goes to Dr. Teman. Dr. Teman, were there any unexpected challenges that you encountered when implementing this CSU ALS protocol?
Well, I think the key is to expect the unexpected. I think that there's no way that you'll be able to predict everything that's going to come up, all of the things that, you know, we certainly didn't think that a year after we started this program, that there would be a worldwide pandemic that would dramatically change our staffing in the ICU, would dramatically change how we had to respond to emergencies and our overall capabilities for things. So I think it's very important, you know, I mentioned that the constant debrief process. I think that's very important as you start this, you know, constantly reflecting on things. You are not going to be able to predict everything that's going to be unexpected, but you have to expect that. There's going to be unexpected events and you have to be flexible and adapt and have a system in place that has that has the ability to account for that.
Thank you, Dr. Teman. This next question is to Dr. Chatterjee. Should cardiac arrest after cardiac surgery be included in the STS failure to rescue quality metrics, along with stroke, prolonged ventilation, renal failure, and reoperation?
Awori, that's a great question. I would say that right now, those 4 complications capture somewhere between 80 to 85% of all mortality that's in the STS database. Cardiac arrest is probably going to add another 5 to 10% of additional mortality, and cardiac arrest is really strongly associated with, you know, prolonged ventilation, often renal failure and whatnot. So I think it would add to it to be able to capture the full information. I think it would also give us more insight into different staffing models and different centers that can look within their own group to be able to see where there might be opportunities for improvement. I think like centers can compare against like centers to be able to see how the different ICU staffing models can compare and respond. So I would say yes.
Thanks, Dr. Chatterjee. Dr. Levine, how important is it to teach the multidisciplinary team in CALS?
Thanks for that question. I think it's vital. Without shadow of a doubt, of the 14,500 people we've trained in the last 6 years, 62% of them have been nursing. You know, I've taught this at over 18 countries around the world, and the first provider is always a nurse. In the US and in Australia, nurse practitioners and PAs are very represented. You have to teach this to everybody. Every provider who is going to be at the patient bedside must know how to do this. I think it's vital.
There is a question from Dr. Aurora from the chat, and I will read it to the panel and seek the panel's opinion about the answer. This is Dr. Aurora's question. I am increasingly aware that in the setting of rapidly deteriorating or arresting patients, rather than have the team focus on chest opening, they should instead focus on getting ready to cannulate the patient for ECMO. Dr. Aurora is interested in the panel's opinion about this, and let me start with Dr. Levine. What is your opinion here?
I come at this from the avenue of simplicity. The vast majority of centres that we have trained this at do not have large ECMO experience. And teaching people to, you can teach a fair number of people to open the chest very, very rapidly. The infrastructure necessary to put people on ECMO very rapidly is a very different thing. And therefore, I think as a first thing for the vast majority of centres, that's what we should concentrate on. There are a large number of centres which do have large active ECMO services, in which case then it would be appropriate. I think but the vast majority of centres that chest opening is what we should concentrate on.
Thanks, Dr. Levine. Dr. Teman, chest opening versus prepping for ECMO, which one?
So I agree with Dr. Levine. I think chest opening is more important in this patient population. The first reason is that in a lot of cases, opening the chest will be therapeutic. If there's a cardiac tamponade, you'll relieve that. If you need to do internal defibrillation, you'll be able to do that, or internal cardiac massage. So a lot of times you don't even need to put the patient on pump or on ECMO centrally. Furthermore, there's a reason why the survival in eCPR is not very good, right? It's difficult to put somebody on ECMO through the groin when they're actively getting chest compressions, and the rate of vascular injury and other complications is much higher. I can open somebody's chest and put them on central ECMO much faster than I can put them on ECMO through the groin when they're actively arresting.
Excellent. Dr. Ciullo, what do you think?
I would say that I would see this maybe not so much as always as an alternative, but I think they're complementary in ways. I do think sometimes clinical nuance, I agree with Adrian and Nick that, you know, I think as a first course, I think chest compression is more easily taught. I think it's also, it depends a little bit on the center that you're at. I would say that I think if you have a patient who was bleeding a fair amount, I think that patient arresting is different than if you have somebody who's at 20% EF, had sort of a longer operation where you think it's ischemia. You know, I think those, you know, those cases might be more appropriately, you know, a peripheral ECMO first. So I think there is a little bit of a nuance, you know, this is getting past, you know, CALS 101. I think there is some subtle nuance to it, which is why, you know, I think it's important to make sure that the communication also goes to the attending surgeon, because sometimes I think there are things that are said and things that are unsaid, and which direction in which to prioritize, I think sometimes can make a difference.
Dr. Morton, what do you think?
Thank you. Yeah, I agree with Suba. It's a little more nuanced. I think first and foremost, the priority for chest reopening is important because, as Dr. Teman shared, it can solve the problem. We can, you know, alleviate the tamponade. However, I think it also serves as a bridge to our teams to get the ECMO equipment to the room and be able to cannulate either centrally or peripherally. We know that internal cardiac massage is an enhanced resuscitation approach compared to external CPR and provides greater cerebral and coronary perfusion pressures than external CPR. So I think getting into the chest and allowing the patient that opportunity to have an enhanced resuscitation as a bridge to potentially deploying the ECMO is important.
Thank you. Allison, would you answer that question as well, please?
Yeah, I would agree with what everyone else has said, especially Dr. Levine. You know, not every institution has an ECMO program. For those that do have ECMO programs, I would highly encourage the process to activate these teams be simultaneous or linked in some way. We're very lucky to have a very strong ECMO program here at UVA, and they are part of the blast page. So even if we're not requesting ECMO, they're aware that there's an open chest. They're aware that they may be requested very quickly. And that works very seamlessly. So they show up with their cart, even if we haven't called them, and they're aware of the patient. So if you are at a program that does have an ECMO program, definitely make that a seamless and simultaneous activation.
Thanks so much, Allison. So the next question we have for our panel is, what protocol do you use for patients who underwent a minimally invasive thoracotomy as opposed to a sternotomy? Dr. Teman, can we start with you?
Sure. So those patients who have not had a sternotomy, we do not include in our CSU ALS protocol. They would kind of fall under more likely to get ECMO just because of, again, there's probably going to be a significant delay. I mean, we do have a sternal saw in our unit, and we have used it, but I think that in that case, the time to be able to get into a some sort of central ECMO situation or central cannulation situation is going to be much longer than going peripherally. So in that case, we would tend to do peripheral ECMO.
Dr. Levine, what are your thoughts?
I think from the point of view, the first thing to do is to make sure that everyone's on the same page. Because I've worked in institutions where someone's suddenly said, I'm going to start doing port access mitrals. A patient with the port access mitral turns up, and then something bad happens and no one knows what to do. Therefore, the first thing you've got to do is make sure that everyone's on the same page and has a plan. After that, I think it depends on two factors. Firstly, have you got a virgin sternum or not? If you've got a virgin sternum and you've got surgeons on site and a saw, then you can open the chest relatively rapidly. If on the other hand, you haven't got a virgin sternum, for example, the reason you've done the minimal access technique is because it's a third time redo, in which case I think I agree, peripheral cannulation and going back to theatre is the way ahead.
And Dr. Morton, what do you think?
Yeah, I think it's somewhat complex of a question. It really depends, as Adrian alluded to, the reason for a minimally invasive. Was it cosmetic? Was it a previous intervention in the sternum? But I'd like to highlight that the protocol offers us opportunities to intervene early in the patient's behalf that might be successful with the inclusion of stack shock or attempts at epicardial pacing that really are not well fit in other resuscitation protocols that often can help be beneficial in rescuing the patient in advance of even other more invasive surgical procedures in the ICU.
And Dr. Chatterjee, what has your experience been like at Baylor?
We would do what Erin says, try to pace, try to shock, and then get ready to peripherally cannulate for ECMO.
And Allison, anything else to add to this panel's discussion here?
Yeah, I would echo what Erin said. That's really what we teach our nurses and our APPs who come to this class. The goal of this training isn't necessarily to save a patient who is in cardiac arrest. That's part of it, but our goal is to prevent the cardiac arrest. So it does help us to increase the knowledge base of our staff. And it also, if you do have a surgeon there and a surgeon decides, I am going to open up this minimally invasive incision, which we have had happen, you do have a staff that is more prepared for that, better trained for that, and more comfortable with that. So even though it doesn't fit the protocol, it certainly helps in their training and education and preparedness.
The next question will be specifically to Dr. Levine, and the question is, have there been attempts thus far at demonstrating efficacy in the reduction of failure to rescue rates? What can you tell us about the difficulties in establishing methodology for these kind of things?
Okay, well, there has been 2 attempts, and this has been very, very successful. One was by Jill Lay in the group in San Francisco, which demonstrated a reduction in failure to rescue in a cohort of patients between 2006 to 9 against 9 to 12. And that definitely demonstrated reduction in failure to rescue rate. There was also work done in a hospital in the United Kingdom in Brighton, which demonstrated very, very similar things. But when we've tried to look at it in the UK and Australia at a national level, we have found a fair amount of difficulties. And that comes at two ways. Firstly, it's looking at the database. It's trying to add in or remove fields from databases, which have been relatively difficult to do. I know it sounds like minutiae, but it's often very difficult to do indeed. The second thing is you often find yourself talking to multiple groups, surgical groups on one hand, resuscitation and intensivist groups on others. And whereas one set of databases you can get to, other sets of databases are very, very difficult to change and also to alter in any way. And I can give you an example of that. In the United Kingdom, we wanted to try and work out how long it was between someone arresting and having their chest open, and to try and add in a number of fields into our ITU data set proved completely and utterly impossible. So it has actually been methodologically difficult just to do things via admin. And I would say that if there is anybody that's going to be able to do this across a large number of healthcare systems, I think it's the STS. I think it's you lot.
Thanks, Dr. Levine. Our next question is, how have members of the panel overcome the barrier where the surgeons have a quote unquote hard no stance on having anyone other than surgeons opening the chest, i.e. They don't want any other team members that have not been trained on this to perform in this function. Dr. Chatterjee, can we start with you?
So we are in our institution, just based upon the number of fellows and surgeons that we've had, we have not actually encountered. Basically, we've always had somebody from, a surgeon available, in terms of that. And to be honest, we do have a little bit more of a reluctance, in terms of that. So I think that's sort of the thing. I think there is probably I think the right way would be like a situation where people are trained appropriately and then the whole team, including the surgeons, develop confidence in the team. You have to recognize this is an infrequent event. These things happen 1% to 2% of cases. But I'd be very interested to see what the other panelists, Nick and Adrian, and Aaron and Allison, what you found.
Yeah, and on that note, Dr. Teman, what do you think?
Well, I agree. I think this is tough. I mean, cardiac surgeons, as a general rule, don't always love change. Don't always love, I mean, this is going against a lot of traditions and things like that. But the fact of the matter is that, more and more, there aren't always surgical residents in the hospital, and there aren't always people that are trained to do this. And I think that's the selling point, is that, you can wait for somebody to come in to open the chest, or you can get that process started. We're not asking people to cannulate for central bypass or anything like that. We're talking about, opening a skin incision, taking some sternal wires out, relieving some tamponade, and by that time, the surgeons are there to do whatever needs to be done to address whatever needs to be addressed there. And so I think, I still remember one of the first times that we utilized this, and one of the surgeons who, kind of begrudgingly came to my office and said, "Wow, that patient is alive today because of that." And so I think it's that. I think it's focusing on those outcomes, focusing on what those results look like, and looking at the alternative. I mean, I think that the alternative is that the patient is not going to survive, and I think that's a pretty valuable thing to offer.
Allison, what's your perspective on the matter?
Nick was being kind by not also pointing out that I was also against introducing this at our institution. I had a lot of hesitancy for this, and I think I probably joined some of our cardiac surgeons in that hesitancy. And to the point of training, I think that's absolutely the answer here. This can't be done haphazardly. This needs to be done in a systematic way. And so eventually, I said to Nick, well, if we're going to do this, I'm going to be in charge of this, and we're going to make sure that we do this correctly. We're going to make sure that our folks feel as comfortable as possible. Nobody ever feels good doing this. One of the best things that was ever said to me was the first time that I ever had to perform this protocol at a different institution. One of the surgeons said to me, I've done this X amount of times in my career, a handful of times, and I've never felt good about that. And that's the point. No one is going to feel good about this, and getting the appropriate training, the appropriate reps really is going to increase your success of this. And I think you can take papers, you can take data, and that was relatively convincing to, I think, some of our folks internally. And a lot of the panelists on this have been those who have published those papers and that data. But what's really going to make a difference is seeing how well prepared your folks are and how much better they are in all emergencies, not just a chest reopening.
And Anna, if I could just add to that, I think that's really where the role of the team leader in any code is really critical. Because I think if the team leader has a calmness and has a steadiness to him or herself, I think that's translated throughout the team. I think if the team leader is chaotic, that again, I think that then it's not going to turn out well usually.
Absolutely. Dr. Morton, your thoughts?
In reference to, I would say, the hindrance or objection to non-physicians from opening the chest, I think that you got to get to the ideology of the pushback or the obstacles, so to speak. Is it a concern for lack of participation, lack of awareness or inclusion in the process? And I think you overcome that by good communication and developing a well-oiled working machine between your surgical colleagues and your ICU team. They cannot say enough importance about how fostering that relationship is key in patient care. And as Dr. Teman shared, it is challenging with even having a lot of fellows around from the surgical training services. Oftentimes they're busy working in the middle of the night doing transplants and emergency cases. So we have to be able to provide the best care for the patients at all hours of the day or night, weekend, holidays, et cetera. So really having a well-rounded team that is able to perform this and is authorized to perform this is key. And I think you use the data to help support that argument.
And Dr. Levine, any additional thoughts?
No, I'd like to echo all of these things, but I think the times, when we started 18 years ago, there were loads of people who said, no one other than the surgeon's going to do it. But as time has gone on and there's been acceptance of the idea, then people have just got with the program. And I think, as Aaron said, and Nick said, that increasing confidence, and as Shuba said, in teams and team leaders has meant people go, okay, there's going to be times where even if there is a clinical fellow theoretically with me, I'm going to be in surgery doing a dissection at 2 o'clock in the morning when my valve and grafts has gone off. There is no one else to do it. We have to do this, and that acceptance has just come with time. And so I don't see that as an enormous problem anymore in where I teach.
An excellent spectrum of opinions. Going back to the chat, and this is a question that piggybacks off Dr. Aurora's question, a question from Dr. Javelfar from Emory. Essentially based on the data presented earlier today about CALs, is it appropriate to shorten the window for CALs to less than 10 days in favor of peripheral ECMO? This question will go to Dr. Levine.
A good question. I have two thoughts about this. Firstly, there is no doubt that the second paper that Shuba showed from Papworth demonstrated that the further you go out from the first, from the operation, the less chance you stand of actually getting a survivor from restenotomy. And that's obviously because the pathology which causes the arrest is very, very different. And thus, that what you're looking at initially, that CALS saves you, tamponade and bleeding, it doesn't occur 4 or 5 days down the line. So I think there's that data which is very convincing to say that, maybe it would be right. The other thing to support with that is obviously if you're going to be able to go with that as an idea, that external CPR would probably work for a relative period of time, which would allow you to get on ECMO. So I can, to a degree, buy that. My only caveats are in two groups. Firstly, again, that there might not be an enormous institutional knowledge of ECMO, number one. And number two, there have been a fair number of situations when late restenotomy has needed to be done. And the classic one of this is the pacing wire that comes out, day 10, and that slowly tamponades over the next hour and a half and they rest. So I have two minds about that myself.
Allison, I've got a question for you from our chat. Who makes sure that the open chest cart is properly stocked and items aren't expired, and how frequently is this done?
A great question. We have at the University of Virginia the most robustly, my light just went off, sorry, the most robustly trained PCAs and PCTs out of any institution I've ever seen. So when we have any sort of open chest procedure on our unit, our techs actually are who run the open chest cart. So in our unit, they own the equipment, they own the knowledge, they, I've worked in cardiac surgery for 15 years. They know more about the individual pieces than I do, than some of our surgeons probably do. So in our institution, it's the techs who check. We have one supply tech who makes sure that, like for this week, we've used 2 open chest trays. We have those specially made in-house, and she makes sure that they get restocked and re-sterilized. It can be anybody. It can be the charge nurse as part of their safety checks, checking the defibrillators, checking the regular code cart, checking the open chest cart, just building it into your day-to-day and making sure that somebody owns that. It could be an advanced practice provider. Just making sure that it's one particular person. We're very lucky that our techs are practicing to the top of their scope and help manage that for us.
Thank you very much, Allison. From the chat, we have a question from Dr. Vink from Medellin, and this question will go to Dr. Teman. Dr. Teman, when do you recommend using epinephrine, and in what cases have you used it?
That's a good question. I think that this might be the area that we kind of differ the most from the kind of traditional CSU ALS teachings. I think we're probably a little bit more aggressive about using epinephrine than other centers might be. But that being said, it's always in the context of being instructed to be given either by the intensivist or by the surgeon. So the default is no epinephrine, but in certain situations where the patient is arresting and we're not overly concerned about hypertension causing a problem, we'll give you maybe a half dose or so, a half milligram of epinephrine. Certainly once we get some degree of perfusion back, so if we're able to do internal cardiac massage or something like that. I have not seen the kind of profound rebound hypertension that is obviously the concern here. So I'd say that we're a little bit more aggressive about doing that. And if I'm involved as either the intensivist or the surgeon, I'm usually giving some amount of epinephrine every time, just to see if we can stave off going on bypass or on ECMO.
Shubha, what is your thought?
I agree with Nick. I think in that peri-arrest period, like that pre-arrest period, 0.2, 0.3 mics of epi, sort of at a time, can try to help stave off. Calcium can be helpful, but we look at it the same way. We do a fair amount of aortic surgery cases, and the last thing you want to see with a milligram of epi is a pressure of 300 and a fresh dissection. That's not going to turn out well. So I agree with Nick.
Almost in closing, as we approach the end of this webinar, Dr. Levine, what is your answer to that question?
I agree with Nick and Shubha there, especially the aortic practice. I have 1 or 2 really bad memories of things like that occurring. But I agree. It's a peri-arrest situation, isn't it? It's where the pressure's 30, 40, you're there, you're thinking to yourself, am I going to open the chest or not? And, you say, okay, we'll give them half milligram of adrenaline, see how it goes. And that suddenly, that just sort of kicks them out of it. And suddenly you're in a different place. But, I think luckily not many of us have seen the reverse situation, which is the milligram of epi and then people reconnecting the pacing wires and the pressure going up to 300. I think that's, thankfully not that much seen anymore.
And for our last question, Dr. Teman, where can centers go to find information on starting this protocol, or maybe some training centers near them?
Absolutely. So I think the CSU ALS organization is fantastic. They have a great website with a lot of great resources. And so I think I encourage everyone to look into the training centers nearby. Please feel free to reach out to me. I can help get you in touch with those folks as well. But I think there's a lot of great resources on their website in that organization.
Alas, we are out of time after yet another thoughtful and insightful hour. I'd like to thank our expert panel of speakers for sharing their expertise with us this evening. My gracious co-moderator, Dr. Ciullo, the STS staff, Michelle and her team, and last but not least, the Society of Thoracic Surgeons for the commitment to the provision of evidence-based clinical practice. Please stick around for the last 30 seconds as we advertise the next setting of our annual perioperative meeting. Thank you and have a great evening.
A sincere thanks to our panelists for your participation and insight. What a rich discussion. Thank you so much. It is not too late to register yourself and your members of your critical care team for the STS Perioperative and Critical Care Conference kicking off on September 8th in Denver. The agenda will include dynamic presentations and expert panel discussions on topics such as ICU dilemmas, ECMO challenges, contemporary management of atrial fibrillation, and more. Visit sts.org/criticalcare or scan the QR code to learn more. Join us for the next STS webinar on Thursday, September 15th, segmental resection for lung cancer. Details will be available soon on sts.org. Thank you and good night.